Well, beginning first with endovascular interventions, this is a standard aortic stent for stenosis. This is not an aortic stent graft. This is a simple stent structure like a stent anywhere, and you can see the linear stent structure within this aorta. We're going to walk the Doppler through this. In this particular case, there was some flow defined outside of this stent, and that would not be so unusual because this is it can go through the interstices of the metal of the stent. What we want to do is make sure that there's no restenosis through the stent. Look at the treatment length. So we're going to look at the inflow, the outflow, and the entire treated segment of that. This is an example of iliac stents. Now these are bilateral kissing stents. You can see in transverse here that they are in the common iliac right up to the level of the distal aorta. And we're going to look for good wall apposition and make sure that these are symmetrical and that they're fully deployed. We're going to get all the velocities that we need to get through all that segment. Usually if the patient has had a full aorta iliac and this is just a follow-up to a post-procedure stent, we would just do the terminal aorta and then look at the whole segment of the iliac since both iliacs were treated. We would walk the Doppler right on through the segment of the treated portion or of the stented iliac and confirm all of that with spectral Doppler in several areas. Most stents in the United States are nitinol, and most stents in Europe currently today are stainless steel. And even though most stents are nitinol that we see, depending on what the manufacturer is and how the stents are put together, they do image quite differently. You can see that these two have a very different imaging profile, but they're generally pretty easy to see, and if you rotate your hand back and forth, you can see where they begin and end, because those endpoints are important. You can see in this stent that there's still a plaque burden. This has crushed the plaque, but not all the way to the wall of the artery, so that leaves the end of this stent kind of hanging loose here and not quite all the way opposed to the wall, and that's something I'd want to note and keep track of as we follow that patient. Again, we're going to be looking for apposition to the wall of the artery, and you can see here another segment of plaque burden underneath this. The plaque has been crushed as far as it could crush towards the wall, but this is still a widely patent stent. These have a higher level of, or less of compliance, a higher stiffness level, and so there's going to be, in general, we expect some higher velocities through stented segments like this than we get in native vessels. And again, we're just really paying attention to this stent and the opposition to the wall of the vessel. Color is helpful to walk through there, and you can, again, just like in a native vessel, look for any alising or places where you want to place your spectral Doppler. So we're going to assess the entire length of the stent with Doppler, looking at the pre-stented segment, the origin, the proximal, mid, and distal portions, and then the outflow portion of that as well. Here's an example of a common iliac artery stent stenosis, and you can see very easily where that is narrowed within the lumen. We document the elevated velocity associated with that. This one happens to be over 500 centimeters per second, and then document the post-stenotic turbulence and the decrease in velocity after the stenosis. This is an example of a subintimal angioplasty with stent. This is where they tunnel underneath and in between the intimal medial segment, create a new lumen in occluded segments, and then they may or may not place a stent within that to keep that segment open. And we have to walk the Doppler throughout that stented segment, just like we do with any stent. Here's an evidence of a distal stent where you can see the stent structure quite nicely up here, and then some turbulence associated right at the distal stent, and then going out into the native vessel itself. Here's a case example that's kind of interesting in looking for iliac disease. This is a routine graft surveillance, infrainguinal graft surveillance. The patient had had the graft for many years and came back in for follow-up, and we noticed that the velocities in the graft were in the impending failure range. The graft was pristinely clean all the way through. There was no areas of stenoses. These velocities had dropped precipitously from the previous study, so we knew based on the waveform morphology of a delayed systolic rise time that we had an inflow problem. The outflow was wonderful. There was no problem with it. So we just went up and followed, because this was at the anastomosis at the common femoral artery. We went on up until we found the problem, which was located in the very proximal portion of the common iliac, a very severe stenosis, over 330 centimeters per second. And this was then addressed. You can see the lesion here on angiogram. And this was addressed with a stent. and repaired. His graft was fine afterwards, and since this was threatening his graft, it was good that this was identified early and repaired prior to him losing that very nice vein graft. So here's an aortoiliac stent case, 70-year-old male, referred for evaluation of lower extremity arterial disease. He had calf claudication and ended up with bilateral common iliac and external iliac PTA with stents. So here's what we would see. We've imaged and identified where the stent is. This is the pre-stent, the origin of the stent, and then walking through the stent, all of the Doppler velocity profiles that we need to capture to make sure that we thoroughly have assessed that stent. Then there's another stent in the external iliac, so here's the origin of that, and then proximal stent, mid-stent, and distal stent, and then the right hypogastric or internal iliac is documented as well. As we went further down, there was some increase in the peak systolic velocity at the proximal right external iliac artery and internal iliac artery with turbulence, but there wasn't a doubling of velocity and there wasn't a lot of post-stenotic turbulence, so this was probably not hemodynamically significant. As we went further down into the groin at the level of the femoral bifurcation, there was a large collection noted. This was measured. It was Dopplered to make sure that there was no flow within it, and this was probably associated with the original procedure at the time of stent placement, not affecting any of the hemodynamics of the vessels. Moving on to the left side, the left common iliac artery origin, mid-stent, distal stent, and then the distal vessel, all with relatively normal profiles. There isn't much reversal of diastolic flow, but there's some. As we go on down, we look at the external iliac and then the external stented segment, the mid-external iliac artery and mid to distal external iliac artery, and we've lost the reverse flow component completely by the time we get down that far. And then right as we get down to the interface with the common femoral artery, we see this very tight lesion by color. There's a lot of aliasing, and we see that the common femoral distal to that has an elevated velocity of 264 centimeters per second with post-stenotic turbulence documented. And here is where we see that the tightest portion, the highest velocity collected within that was 455 centimeters per second. So this was a hemodynamically significant lesion. We evaluated then on the runoff for that, the common femoral, the SFA, looking at the lesion. Now, your report on this would be bilateral patent common iliac and external iliac artery stents with a hemodynamically significant stenosis of the left distal external iliac artery right at the origin of the proximal common femoral artery, an incidental finding of that groin complex where we measured it with no associated flow and likely consistent with a hematoma. And this patient underwent an endarterectomy with vein patch angioplasty to address that lesion that we saw that was so stenotic. So duplex assessment following peripheral interventions, we know that identification and treatment of these restenoses may improve long-term patency. It's technically easier to manage a stenosis than wait for it to occlude. And we know that there is a significant restenosis rate associated with PTA and stent. We're going to use our imaging and Doppler data. We're going to look at the pre-op or baseline comparison and really pay close attention to the stent alignment and relationship to the vessel walls. I'm going to move on now from talking about endovascular intervention with PTA and stent and talk about duplex ultrasound following endovascular aortic stent graft, or EVAR. This is a increasing frequency of repair for aortic aneurysms in this country and across the world. And duplex ultrasound is a very good way of following these patients. There seems to be some resurgence of interest in duplex due to frequent CT scans causing an increased dye load and nephrotoxicity problems as well as radiation dose. So it's something that can be done. It's a valuable, reliable tool for post-operative surveillance of aortic endografts as long as you use a proper protocol. It is a much more complex and detailed exam than standard aortic ultrasound for, say, following up an aneurysm. And it is more sensitive to endoleak than, in some cases, than CT or even angiography because it's real-time and not tied to any kind of timing of contrast that has to be administered.